Imagine being stranded in the coldest, most remote place on Earth, no hospital, no rescue, no way out, and knowing that your only chance of survival is to cut yourself open and perform surgery on your own body. This is the story of Dr. Leonid Rogozov in Antarctica, 1961, a moment that pushed human endurance and medical courage to the absolute limit. Before we dive in, where are you watching from? Drop it in the comments below. In the winter of 1961, Novolazarevskaya Station in Antarctica was newly built and already cut off by the polar night. Among the small Soviet wintering team, Leonid Ivanovich Rogozov was the only physician. He was 37 days into his posting when the first symptoms appeared. On the morning of April 29th, he recorded fever, weakness, and a dull pain in the lower abdomen. Within hours, the pain localized sharply to the right side, and nausea and vomiting followed. Conservative measures, including rest and the antibiotics on hand, did not stop the progression. By the following day, signs of peritonitis emerged, and the danger of a ruptured appendix became clear. There was no possibility of evacuation. The nearest Soviet base, Mirny, lay about 1,000 kilometers away. Blizzard conditions made air travel impossible, and with the onset of winter, no ship could reach them. Rogozov wrote in his notes that he realized his only chance was to operate on himself. The decision was made in full awareness that it might fail, but delay meant certain death. The other men at the station improvised a surgical area. They sterilized instruments, arranged lighting, and cleared space on a low table. 2 volunteers were chosen to assist: meteorologist A.N. Artemyev and driver Z.M. Teplinsky. Neither had medical training, but under Rogozov's instruction, one would pass instruments and hold retractors while the other managed a mirror so that areas hidden from direct sight could still be reached. Late on April 30th, Rogozov injected local anesthetic into the abdominal wall. Lying half reclined, turned to his left, he began the incision on the right lower quadrant of his abdomen. The cut measured about 10 to 12 centimeters. He alternated between working by direct vision and by touch. When the mirror proved confusing, he pushed it aside and relied instead on sensation. Twice he was forced to pause because of dizziness and weakness. At one point, while opening the peritoneum, the scalpel slipped and grazed the cecum. Rogozov quickly sutured the injury, aware of the added danger. Pressing on, he located the appendix. It was badly diseased, with a darkened area at its base. He excised it, irrigated the cavity, introduced antibiotics, and began closure. The entire procedure lasted close to 2 hours. Those present later described him working steadily but with visible effort, taking short rests before resuming. The following days brought gradual recovery. His fever subsided by the 5th day, bowel function returned on the 4th, and the wound was healing well by the 7th when sutures were removed. After 2 weeks, he resumed routine duties at the station, and within a month he was able to take part in heavy work. He continued the expedition until its conclusion and returned to Leningrad in October 1962. The Soviet press later reported the event widely, and photographs taken during the operation circulated as evidence of his extraordinary act. Rogozov was awarded the Order of the Red Banner of Labor the same year. In medical literature, his case became a landmark example of survival surgery under isolation, cited in surgical histories and journals alike. In ordinary surgery, the presence of a full team of trained personnel is taken for granted: a surgeon, an assistant, a scrub nurse, an anesthetist. In Rogozov's case, none of these were available. He faced the task of operating in an environment where even the most basic assumptions of surgical safety were compromised. His report notes the absence of any possibility for general anesthesia. Supplies were limited to what had been shipped from Leningrad months before, with no means of replenishment. The only available option was local anesthetic, a 0.5% solution of Novocaine. This meant that he remained fully conscious throughout the procedure, feeling each movement and gauging his own tolerance in real time. The conditions of the operating theater were also unusual. The theater was in fact a small room within the station, never designed for surgical use. Illumination came from a desk lamp and a torch handled by one of his assistants. Temperature regulation, sterility, and airflow were far from hospital standards. Instruments had been sterilized using the expedition's limited equipment, and the table on which he lay was adjusted to allow him to half recline, propped by pillows, a position devised to balance access with the risk of fainting. One of the greatest anomalies lay in the use of a mirror. Rogozov initially instructed his assistants to hold it so that he could visualize the deeper tissues. But he recorded that the reversed image disoriented him. Movements appeared inverted, confusing his hand-eye coordination. He abandoned the mirror except when absolutely necessary, relying instead on direct palpation. This reliance on tactile sensation over visual control is highly unusual in abdominal surgery, where visualization is normally critical. His ability to locate the appendix and recognize diseased tissue by feel was a testament both to training and necessity. Another irregularity was the level of intraoperative complication he encountered. At one point, while opening the peritoneum, he inadvertently grazed the cecum, producing a small injury. In a hospital, an assistant would control exposure, suction blood, and protect the bowel. Rogozov had only his own 2 hands and untrained helpers. He controlled the situation by immediately suturing the injury himself. The fact that he could recognize and repair such an error, while already weakened and semi-reclined, is cited in later medical literature as a remarkable technical feat. The very duration of the surgery, about 1 hour and 50 minutes, was anomalous in itself. Appendectomies in standard conditions with full teams are usually shorter. Yet, under those extreme circumstances, the operation neither dragged on uncontrollably nor ended in collapse. The tempo Rogozov maintained, with planned pauses to regain strength, gave the procedure its own rhythm, unlike the uninterrupted pace of normal surgery. Documentation also emphasizes the improvised postoperative infection control. With no proper postoperative ward, he remained in the same living quarters as the rest of the wintering party. His wound was inspected and dressed daily, with instruments and dressings re-sterilized under the limited facilities available. Antibiotics were administered both locally during surgery and systemically afterward, part of a calculated strategy to prevent peritonitis from progressing. From the perspective of surgical history, the anomalies extend beyond the technicalities of incision and closure. The mere fact that Rogozov performed the appendectomy on himself while under local anesthesia is unique in Antarctic history and exceedingly rare worldwide. Previous recorded autoappendectomies existed, for example, cases in the early 20th century where surgeons performed the procedure on themselves, but none under such conditions of isolation and with the risks of environmental exposure. Later reviews in medical journals note that in the annals of surgery, Rogozov's case remains unmatched in combining geographical isolation, extreme environmental barriers, and the need for immediate surgical intervention by the patient himself. The aftermath also reveals technical irregularities by omission. There were no follow-up imaging studies, no laboratory tests, and no external oversight. Diagnosis, operative decision-making, execution, and postoperative monitoring were carried out by the same individual, with no external confirmation possible. He judged success purely on clinical improvement, temperature reduction, pain resolution, and wound healing. That such an approach sufficed underscores the profound difference between field surgery in extreme isolation and ordinary practice. Years later, when his son Vladislav and historian Neil Bermel summarized the case in the BMJ, they emphasized these anomalies: the lack of anesthetist, the semi-reclined self-positioning, the disorienting mirror, and the absence of trained assistance. Each detail, viewed alone, was extraordinary. Combined, they form a catalog of technical irregularities that make the event unique in surgical records. When Leonid Rogozov made the decision to operate on himself, the human response among his colleagues at Novolazarevskaya station was a mixture of alarm, solidarity, and sober recognition of necessity. The men at the station were not doctors, but they understood the gravity of his condition. Accounts emphasized that they accepted their roles without hesitation when he explained what would be required. Driver Teplinsky and meteorologist Artemyev, untrained in medicine, agreed to assist him during the procedure. Their names are preserved in his report, a sign of how he considered their contribution essential to his survival. The 2 assistants prepared the room under his instructions. One sterilized the instruments, another set up lighting. Others in the station, though not directly assisting at the operating table, helped by maintaining cleanliness and later by monitoring Rogozov during his recovery. The event became a collective trial for the group. They were isolated together, and the survival of one of them, the only physician, was tied directly to their willingness to follow his guidance precisely. Photographs taken during the operation offer another layer of human testimony. In them, Rogozov can be seen reclined, instruments in hand, while his assistant holds retractors. These images, later published in Soviet newspapers and reproduced internationally, carried an immediate emotional impact. They showed not just a technical act of self-surgery, but the determination of a man supported by companions who were neither surgeons nor nurses, yet performed those roles as best they could. His son, Vladislav Rogozov, has described in later accounts how his father downplayed the drama of the event. Leonid rarely spoke of it outside professional or family circles. To those who knew him, he seemed uncomfortable with the attention it brought. For him, it had been a matter of survival and duty, not spectacle. This restraint is consistent with the sparse, clinical tone of his own written report, which avoids sensational detail. It lists symptoms, actions taken, complications encountered, and the sequence of recovery, as though it were any other surgical case history. Within the station, however, the atmosphere was remembered differently. Fellow expedition members reportedly regarded the operation as a moment that bound them more closely together. They had watched one of their own face death directly and confront it with steady hands. While Rogozov did not dramatize his own act, others spoke of it with admiration. For men confined in an Antarctic outpost, hundreds of kilometers from help, the event became a story retold often during their long winter. In the Soviet Union, the broader human reaction was one of awe and pride. Once news of the operation spread, the official press presented it as an example of individual courage reflecting collective Soviet resilience. The photographs circulated widely, not only as medical evidence but as a symbol of endurance in harsh conditions. For those outside the expedition, the human account was mediated through these images and through short press reports. Yet for the 12 men at Novolazarovskaya station, it was a lived experience, one that fused fear, duty, and relief. Decades later, colleagues and family members described the memory as more than just a surgical feat. They recalled the silence of the polar night outside, the tension in the room, and the sense that a wrong movement could mean the loss not only of their doctor but also of the man on whom their health and morale depended. In this sense, the human story extends beyond Rogozov himself. It includes the assistants who steadied retractors with trembling hands, the companions who sterilized instruments with whatever means they had, and the wider expedition team who held their breath while he fought his illness with a scalpel. The fact that he resumed duties within weeks reinforced his role in the group. The men at the station saw him return from patient to doctor, still weak but carrying on. This cycle, from dependence on others to reassuming responsibility for their medical welfare, was itself part of the human narrative. To them, it was not only a story of survival but of resilience, of one man recovering fast enough to continue serving those who had served him. When Leonid Rogozov's operation was first reported in 1961, the details presented to the Soviet public were selective. Soviet media outlets published photographs of the event, showing the young doctor in mid-procedure, reclining with scalpel in hand, assisted by 2 colleagues. The images were striking, and the accompanying reports framed the act as an example of courage and resourcefulness. Yet the accounts given in newspapers were shorter and more polished than the clinical narrative he himself wrote for the information bulletin of the Soviet Antarctic expedition. The bulletin, distributed within scientific and professional circles, preserved technical details. The incision length, the use of local anesthesia, the accidental injury to the cecum, and the timeline of recovery. But in the broader Soviet press, such potentially unsettling information was absent. Instead, readers encountered a simplified story of a brave Soviet man performing surgery on himself and triumphing over the odds. The omission of complications, such as the bowel injury, illustrates one of the first discrepancies between official representation and first-hand record. Later, when Western medical journals and newspapers began to mention the case, discrepancies grew. Reports in Europe and America often drew from Soviet press releases rather than Rogozov's own detailed account. This led to variations in reported times, descriptions of the operation, and the degree of assistance he received. Some versions suggested he worked entirely alone, without any help, while others mentioned untrained assistance. Only the original report makes it clear that two colleagues, Teplinsky and Artemyev, had crucial roles, passing instruments, holding retractors, and managing the mirror. The simplification into a story of solitary heroism suited newspaper headlines but obscured the collective contribution of the station members. Another discrepancy lies in how his condition was described. Rogozov's own notes identified symptoms of localized peritonitis and imminent perforation. Later summaries in Soviet outlets used broader, more dramatic language. A mortal danger or death was certain without immediate action. While this conveyed the urgency, it blurred the precise medical picture. This shift in language reflects the difference between a clinical report and a state-oriented narrative designed for public readership. Recognition also carried uneven traces of official discrepancy. In 1961, Rogozov received the Order of the Red Banner of Labor, one of the Soviet Union's high civilian honors. Official statements framed the award not simply as recognition of medical skill, but as a reflection of Soviet courage in exploration and science. In medical circles, however, the honor was regarded more narrowly as acknowledgement of a rare and successful surgical intervention under extreme conditions. Thus, depending on the audience, the event was either celebrated as an emblem of the nation's strength or analyzed as a unique clinical case. Discrepancies also appear in the preservation of testimony. Within the Soviet Union, accounts of the operation circulated primarily through newspapers, photographs, and occasional mentions in exploration reports. The full translated version of his self-written report only became widely available decades later, after the fall of the Soviet Union, when archival documents were digitized. This delay meant that for many years, non-Soviet audiences knew the story only through abbreviated press accounts. Consequently, misconceptions about the operation became embedded in Western retellings. One notable example is the varying description of how long the operation took. Rogozov's own notes estimate the procedure lasted 1 hour and 50 minutes. Yet some press reports described it as lasting nearly 2 hours, others as about an hour, and some later as more than 2 hours. The discrepancies are small but significant, reflecting how journalistic retellings altered details for simplicity. Similarly, the matter of his postoperative course was streamlined in public reports. Soviet newspapers stated simply that he recovered quickly and resumed work, with little mention of the daily fever, wound care, or gradual return of bowel function that he carefully recorded in his notes. This omission is understandable. Details of postoperative complications were unlikely to serve propaganda goals, but it illustrates how the official narrative diverged from medical reality. International accounts added their own layer of discrepancy. Western journalists sometimes described Rogozov as performing the surgery unaided, despite evidence to the contrary. Others exaggerated the drama, portraying him as working by the light of a single candle, when in fact an electric lamp and a torch were used. These embellishments demonstrate how the story, while rooted in fact, was reshaped according to audience expectations. In later years, his son Vladislav Rogozov worked to reconcile these divergent accounts. In his 2009 article in the BMJ, co-authored with linguist Neil Bermel, he reproduced his father's clinical report and emphasized its precision. Their aim was to correct decades of simplified or exaggerated versions. This act of republication revealed how far the official and popular accounts had drifted from the original. For the first time, a wide international medical audience could read Rogozov's own description, complete with technical detail and acknowledgement of complications. Even within Russian historical memory, the story has been told differently depending on context. In some histories of Antarctic exploration, the operation is framed as a triumph of individual resolve. In surgical histories, it is analyzed as a rare example of autosurgery. In family recollections, as preserved by Vladislav, it appears as a personal event his father rarely discussed, one he considered necessary but not heroic. The discrepancy between private modesty and public heroization is as striking as any technical detail. What remains consistent across all accounts is the outcome. A successful operation performed under extreme isolation, followed by recovery and eventual return to duty. Yet how that outcome was narrated, whether as propaganda, clinical case, or family memory, shows the layers of discrepancy between official Soviet reporting, Western press summaries, and the full medical record. Each version emphasized different aspects, leaving historians and physicians the task of piecing together the most accurate composite from these fragments. The self-operation of Leonid Ivanovich Rogozov did not vanish into obscurity after his return from Antarctica. Instead, it left a layered legacy that reached medicine, exploration history, and public culture alike. Each sphere remembered the event differently, but together they sustained its place as one of the most unusual surgical episodes of the 20th century. Within the Soviet Union, Rogozov's case was quickly framed as an emblem of resilience. Newspapers in 1961 presented it as proof that Soviet explorers were equal to the challenges of the Antarctic environment. The award of the Order of the Red Banner of Labor cemented his story as one of personal heroism serving collective national pride. Yet, within the professional world of Soviet medicine, the case was documented in a less exalted, more technical manner. His detailed clinical report circulated in the information bulletin of the Soviet Antarctic expedition and was later archived for scientific reference. This dual reception, heroic in public, clinical in specialist circles, foreshadowed the multiple legacies that followed. In global medicine, his case became a standard reference point for discussions of autosurgery. It appeared in surgical histories such as reviews of appendectomy through the centuries, where it was cited as perhaps the most dramatic example of necessity-driven self-operation. Medical journals often invoked it when exploring questions of surgical improvisation, emergency procedures in extreme environments, or the psychological capacity of surgeons under stress. In classrooms and lectures, it became a case study not just of surgical technique but of decision-making under isolation. In Antarctic history, the event took on a different resonance. Among accounts of polar expeditions, which often highlighted endurance, sacrifice, and improvisation, Rogozov's act fitted naturally. It stood beside stories of explorers who had amputated frostbitten fingers, trekked hundreds of kilometers on starvation rations, or overwintered in darkness without resupply. Yet his contribution was distinctive. Rather than physical endurance alone, it displayed medical knowledge adapted to survival. For historians of exploration, it demonstrated how the human body itself could become both patient and instrument when isolation stripped away every safety net. For decades, however, access to Rogozov's full voice remained limited outside the Soviet Union. Only after 1991 did translations of his original report circulate more widely. In 2009, nearly 50 years after the event, his son Vladislav published an English-language account in the BMJ, co-authored with Neil Bermel. This article reintroduced the case to a global readership with clinical accuracy, correcting misconceptions that had spread through decades of press retellings. By reproducing photographs and excerpts from his father's original notes, Vladislav not only restored precision but also added a human dimension, describing his father's personality and quiet approach to the memory. The republication in a prestigious medical journal also gave the event a second life in the era of online sharing. Newspapers and websites around the world retold the story, often illustrating it with the stark black and white photographs from 1961. In this new round of attention, Rogozov's act was no longer embedded in Cold War propaganda but in a universal admiration for individual resolve. The framing shifted from Soviet heroism to human resilience, expanding its legacy beyond national context. In Russian cultural memory, Rogozov became a symbol not just of medicine but of self-reliance. Documentaries and retrospectives on Antarctic exploration regularly included his case. Museums that chronicled polar history displayed the photographs, instruments, and records. His name appeared alongside polar pilots, meteorologists, and geologists who had faced severe conditions in the service of exploration. The persistence of the story in these contexts shows how his act transcended its immediate medical relevance to become part of national heritage. Another layer of legacy lies in the ongoing use of his case as an example in extreme environment medicine. When space agencies and polar programs consider medical preparedness for remote stations or long-duration missions, Rogozov's case is often cited as a warning and a lesson. It illustrates the risks of isolation and the potential need for trained medical personnel to confront emergencies without outside support. Discussions of human missions to Mars or lunar bases sometimes invoke his story as an analogy for the necessity of surgical capability in environments where evacuation is impossible. Within the Rogozov family, the legacy was remembered more quietly. Accounts from his son suggest that Leonid himself rarely spoke of the event after returning to Leningrad. He resumed his surgical career, completed his dissertation, and worked as a physician and teacher until his death in 2000. To his colleagues and students, he was known more for his contributions in thoracic surgery and clinical practice than for the episode in Antarctica. Yet for those who knew the story, he remained the man who had once performed surgery on himself, a fact that overshadowed even decades of medical service. Even today, more than 60 years later, his case continues to circulate in medical education, popular science writing, and historical reflection. It is cited not only as an extraordinary event, but also as a reminder of the intersection of knowledge, necessity, and human resilience. Unlike many tales of survival that end in tragedy or myth, Rogozov's act is documented in his own words, preserved in photographs, and supported by the testimony of his companions. This solid documentary foundation ensures that the legacy endures not as legend but as history. Self-surgery has a scattered but fascinating record in medical history. Rogozov's operation in 1961 stands out for its circumstances: an isolated Antarctic station, no possibility of evacuation, and the necessity of abdominal surgery. Yet other instances, across centuries, illustrate both the rarity of such acts and the extraordinary determination they represent. Comparing them allows a fuller appreciation of why Rogozov's case remains unique. One of the earliest documented examples was that of Evan O'Neill Kane, an American surgeon from Pennsylvania. In 1921, Kane performed an appendectomy on himself at Kane Summit Hospital. Unlike Rogozov, he was not isolated, nor was he compelled by urgent illness. His operation was intended as a demonstration. He wished to prove that general anesthesia was unnecessary for many procedures and that local anesthesia was safer for certain patients. He administered Novocaine to himself, made a standard incision, and removed his own appendix in about 30 minutes. His colleagues observed, and he recovered without complication. 8 years later, in 1932, Kane again operated on himself, this time repairing an inguinal hernia. Though successful, he later died of pneumonia unrelated to the surgery. His cases are well documented in medical literature, and they illustrate a contrast. While Kane operated in a fully equipped hospital with staff nearby, Rogozov did so in an environment of isolation and risk, with death as the immediate alternative. Another example came from South America in 1961, the same year as Rogozov's ordeal. Dr. Jerry Nielsen, later famous for her own self-treatment in Antarctica in 1999, was not the first woman physician to attempt self-intervention, but she became one of the most widely known. Stationed at the Amundsen Scott South Pole Station, she discovered a breast lump during winter over, when evacuation was impossible. With remote guidance via satellite, she performed biopsies on herself, assisted by station staff. When the biopsy suggested malignancy, she began chemotherapy using supplies airdropped by the U.S. Air Force until she could be evacuated months later. While this was not open abdominal surgery, it drew direct comparisons to Rogozov's case. Both were physicians forced to act on their own bodies in Antarctic isolation, supported by untrained colleagues. Other cases illustrate different motivations. In 2000, Dr. Arno Buntgen, a German surgeon, removed a lump from his forearm during an expedition in the South Atlantic. In 2004, news surfaced of Dr. Daniel Alberti, an Argentine physician stationed in Antarctica, who also performed an autoappendectomy after presenting symptoms similar to Rogozov's. Though less publicized, his case was reported by Argentine outlets as a reminder that medical emergencies in polar environments still posed risks decades after Rogozov's time. Perhaps the most harrowing example outside professional medicine was that of Inés Ramírez Pérez, a woman in rural Oaxaca, Mexico, in March 2000. With no medical assistance available, and in obstructed labor, she reportedly drank alcohol, took a kitchen knife, and performed a self-cesarean section. She successfully delivered her child, later received surgical repair, and both mother and child survived. Her case was documented in the International Journal of Gynecology and Obstetrics. While not performed by a trained physician, it remains one of the few medically verified instances of survival following self-cesarean. It illustrates the extreme end of necessity-driven self-surgery, carried out under conditions even less favorable than Rogozov's. These cases, when placed alongside Rogozov's, highlight several points of comparison. Kane's operations were elective demonstrations. They carried symbolism but little mortal risk. Nielsen's biopsies and chemotherapy were self-directed under remote guidance, reflecting advances in communication unavailable to Rogozov in 1961. Ramirez Perez's case shows self-surgery outside the medical profession, carried out under desperation with no instruments or sterile environment. Rogozov's operation lies between these extremes. It was neither elective nor improvised without knowledge, but a trained surgical procedure carried out under severe isolation and mortal necessity. Medical literature often groups such cases under autosurgery or autoappendectomy. Reviews emphasize how few are fully verified. Many anecdotal reports exist, but only a handful are confirmed by first-hand documentation and photographic or medical evidence. In this sense, Rogozov's act is one of the most securely documented. His clinical report, the eyewitness photographs, and later republication in medical journals ensure its status as historical fact rather than legend. The comparative perspective also reveals how the environment shapes perception. Kane's operation, though unusual, was more curiosity than survival tale. Ramirez Perez's case was framed in human interest journalism as resilience born of poverty and isolation. Nielsen's biopsies became a story of modern telemedicine and international cooperation. Rogozov's act continues to be framed as a story of Antarctic endurance, Cold War-era exploration, and the limits of human self-reliance. Across these cases, the common threads are necessity, isolation, and determination. Yet no other case combines them in quite the same way as Rogozov's. A young physician at the edge of human habitation, faced with imminent death, performing a major abdominal operation on himself with 2 untrained assistants, and surviving to resume duties. This is why his legacy, though part of a broader lineage of self-surgery, remains singular. The medical and psychological dimensions of Leonid Rogozov's operation reveal why his case continues to attract attention decades later. On the clinical side, it represented a technically competent appendectomy, performed under local anesthesia with minimal equipment. On the psychological side, it required concentration, resilience, and the suppression of panic while operating on one's own body. A task very few individuals could attempt, let alone complete successfully. From the medical standpoint, the challenges were profound. Performing abdominal surgery requires visualization of structures, careful hemostasis, and layered closure. Rogozov confronted all of these with diminished visibility, absence of trained assistance, and a compromised physical state. He was febrile, nauseous, and already weakened by peritonitis. These physiological factors normally contraindicate a surgeon attempting fine motor tasks, yet he managed them effectively. He injected his own abdominal wall with Novocaine, gauged the adequacy of anesthesia, and made the incision with deliberate pace. His ability to continue while experiencing dizziness demonstrates an exceptional balance between clinical judgment and self-control. Psychologically, self-surgery demands compartmentalization, the ability to divide oneself into patient and surgeon simultaneously. Rogozov's report reveals a strikingly clinical tone, describing his own abdomen and symptoms with detachment, as if they belonged to another patient. This detachment likely served as a protective mechanism, allowing him to focus on the technical sequence rather than the personal threat. Later analysis by his son and co-authors in the BMJ highlighted this aspect, suggesting that his training as a surgeon equipped him to suppress the natural instinct to recoil from self-inflicted incision. The presence of assistants, though untrained, may also have played a psychological role. Their function was partly technical, handing instruments, holding retractors, but also moral. The knowledge that others were present to follow instructions provided Rogozov with a sense of external structure, preventing the procedure from collapsing into solitary chaos. This echoes broader findings in psychology. Even unskilled companionship during stressful tasks can stabilize performance by reducing the perception of total isolation. In comparative terms, self-surgery cases show similar psychological traits. Evan O'Neill Kane, when operating on himself in 1921, displayed calm and even humor, according to reports, treating the procedure as demonstration. Ines Ramirez Perez, performing a self-cesarean in 2000, attributed her survival to determination born of necessity and maternal instinct. Jerry Nielsen, during her Antarctic biopsy, described fear but also the mental discipline of breaking the procedure into small, manageable tasks. Rogozov's case fits this pattern. Success hinged on the ability to reframe an overwhelming threat as a sequence of steps. Physiologically, stress produces cascades of hormones, adrenaline, cortisol, which can sharpen focus but also cause tremor and impaired fine control. Rogozov acknowledged episodes of weakness and dizziness during the operation. His decision to pause, rest briefly, and then continue reflects sound clinical self-awareness. Rather than pushing to the point of collapse, he regulated his own performance, an approach consistent with survival psychology literature that emphasizes pacing and self-monitoring in crises. Pain tolerance was another crucial factor. Local anesthesia blocked sensation at the incision site but could not eliminate deep visceral discomfort. Rogozov worked while feeling pressure, stretching, and internal manipulation. His ability to persist through such stimuli suggests both personal fortitude and the anesthetic efficacy of Novocaine in that context. Modern accounts note that the psychological expectation of pain can amplify its intensity, yet Rogozov's clinical detachment likely muted this amplification. Another dimension is the psychological aftermath. According to his son, Leonid seldom spoke of the operation later in life. He neither exaggerated it nor treated it as a defining identity. This reticence may reflect a desire to move past a traumatic experience. In psychological terms, it aligns with coping strategies seen in survivors of extreme events who integrate the memory privately but do not dwell on it publicly. For him, the operation was necessity, not legend. Medical analysis also extends to implications for extreme environment medicine. Studies in aerospace and polar medicine cite Rogozov's case when discussing medical autonomy, the degree to which an expedition must handle emergencies without outside support. The lesson drawn is that self-surgery, while heroic, is not a reliable contingency plan. Instead, missions should include redundancy in medical staffing, telemedicine capacity, and training of non-physicians in basic emergency care. Rogozov's survival demonstrates what is possible, but it also underscores systemic vulnerability. The entire station depended on one man who nearly succumbed. From a broader psychological perspective, the story exemplifies human adaptability. Under extreme threat, with limited options, individuals may transcend ordinary thresholds of fear and pain. Rogozov's self-surgery stands as a case where professional training, necessity, and psychological resilience converged. It illustrates not only what can be endured, but also how the mind can impose order on chaos, transforming imminent death into a controlled sequence of surgical steps. The autoappendectomy of Leonid Rogozov did not remain an isolated curiosity in the annals of medicine. For planners of future polar expeditions and space missions, it became a cautionary episode that highlighted vulnerabilities in medical preparedness. His survival was a triumph of individual skill and resilience, but the circumstances that forced him to operate on himself revealed systemic gaps that institutions sought to prevent in later decades. In the context of Antarctic expeditions, one of the clearest lessons was the necessity of medical screening. After Rogozov's return, Soviet and later Russian Antarctic programs placed increasing emphasis on thorough pre-deployment evaluations. Potential expeditioners, especially those without medical training, were required to undergo appendectomy and sometimes other prophylactic surgeries before assignment to remote stations. The rationale was direct. If an inflamed appendix could lead to such danger for a physician, it could prove fatal for a layperson with no surgical expertise. This policy mirrored measures already adopted by some military and polar organizations, where prophylactic removal of the appendix or wisdom teeth was recommended for personnel in isolated environments. The second lesson lay in redundancy. Rogozov was the sole doctor at Novolazarevskaya station. His illness exposed the station to dual vulnerability: the potential loss of their only physician and the loss of the person responsible for medical care of all others. Subsequent expeditions increasingly sought to assign more than one individual with medical training or, at minimum, to provide robust cross-training for non-medical personnel in emergency procedures. While logistical and financial constraints often limited staffing, the principle of redundancy gained recognition as essential to risk management. Advances in telemedicine also trace part of their history to such cases. In 1961, Rogozov was beyond the reach of radio consultation. The Antarctic winter cut off not only physical evacuation but also rapid communication. By the 1980s and 1990s, however, satellite technology allowed doctors in polar stations to consult specialists remotely. This capability reached global attention in 1999, when Dr. Jerry Nielsen at the South Pole received diagnostic and treatment guidance from oncologists via email and teleconferencing. Her case and the airdrop of medical supplies to her station showed how lessons from Rogozov's era had been partially addressed through technology. What he had faced alone, later expeditioners could face with virtual support. For space agencies, Rogozov's case offered a particularly stark lesson. Spaceflight, like polar exploration, isolates humans in environments where evacuation may be impossible. Both NASA and Roscosmos have cited historical precedents such as his autoappendectomy when developing medical contingency planning for long-duration missions. On the International Space Station, astronauts receive extensive medical training before flight, and the crew medical officer, often a physician but not always, is equipped to handle emergencies with telemedicine support from Earth. The case of Rogozov is frequently invoked in discussions about missions beyond low Earth orbit, such as lunar bases or Mars expeditions, where communication delays and lack of evacuation options make self-reliance paramount. Policy discussions in aerospace medicine often highlight three strategies: preventive surgery, enhanced medical training, and robotic or minimally invasive support systems. Rogozov's experience directly reinforces the first two. Preventive appendectomy remains under consideration for astronauts destined for long-duration missions. In 2019, for instance, a European Space Agency review noted that pre-mission appendectomy had been performed for some candidates to eliminate risk. Medical training has expanded to include not only routine procedures but also simulation of emergency surgery under guidance. Rogozov's case is often cited in training literature as an example of why these measures matter. The legacy of his ordeal also shaped how institutions think about morale and group resilience. In Antarctica, his fellow expedition members played critical roles as assistants, despite having no formal training. Policies since then have increasingly recognized the importance of equipping all expeditioners with basic first aid, trauma management, and psychological support skills. The idea is not to create substitute surgeons, but to provide a foundation that can stabilize emergencies until professional intervention is possible. Rogozov's survival owed something to his assistants' ability to follow instructions under stress, a precedent that policymakers use to justify cross-training for all members of isolated crews. Beyond medicine, Rogozov's case has influenced broader planning philosophy. It underscored that isolated missions cannot rely on evacuation as a fallback. Instead, they must assume self-sufficiency in every domain: energy, food, shelter, and health. For Antarctic stations, this principle meant stockpiling medical supplies beyond immediate needs, ensuring sterilization equipment, and maintaining surgical-grade lighting and instruments. For space missions, it means designing medical kits that include not only pharmaceuticals but also tools for invasive procedures, alongside guidelines for their use under microgravity conditions. In retrospective analyses, experts often describe Rogozov's operation as both inspiring and alarming. Inspiring because it proved human capacity to endure and adapt under unimaginable stress. Alarming because it revealed a system that placed a crew in a position where survival depended on such extremes. Policy responses since the 1960s have aimed to minimize the chance that any individual would again be forced into such an ordeal. Yet the memory remains embedded in institutional cultures. In Russian polar medicine, the photographs of Rogozov operating on himself are still used in teaching, both as an example of courage and as a reminder of why redundancy and prevention are vital. In space medicine, his name appears in training slides and policy reviews, symbolizing the high stakes of medical autonomy. The broader policy lesson is not that autosurgery is a viable contingency, but that systems must be built so that no one ever needs to repeat it. When Leonid Rogozov operated on himself in April 1961, the event was initially documented in clinical form, then reframed for broader Soviet audiences. The earliest popular representations emerged in newspapers and magazines, where photographs of the procedure were published alongside brief, dramatic accounts. These images, stark black and white photographs of a man reclining with scalpel in hand, assistants holding retractors, were among the most powerful medical images ever released to a general audience. In the Soviet press, they functioned as symbols of courage, technical mastery, and national resilience during an era when stories of endurance were part of the cultural fabric of Cold War competition. Unlike many Soviet heroes, Rogozov was not made into a household name with biographies or monuments during his lifetime. Instead, his act circulated as a remarkable episode, included in anthologies of exploration and medicine. In the Soviet Union, it appeared in schoolbooks and exhibitions on Antarctic exploration, often placed alongside narratives of aviators, cosmonauts, and polar scientists. In this way, his story entered collective memory less as an individual saga and more as part of a tapestry of Soviet achievements in hostile environments. Internationally, the photographs gained symbolic weight of their own. Reproduced in Western magazines and later in medical histories, they became visual shorthand for human determination. Over time, the starkness of the images, a surgeon operating on himself in isolation, encouraged mythologizing retellings. Popular accounts in books of medical curiosities and extreme survival stories often presented the surgery as almost unimaginable, at times stripping away context to emphasize the drama. In the 1970s and 1980s, English-language anthologies of bizarre or heroic medical feats almost always included Rogozov, usually alongside Evan O'Neill Kane and later Ines Ramirez Perez. The late 1990s and early 2000s brought a resurgence of interest, particularly online. The internet facilitated circulation of the iconic photographs, sometimes without accurate captions or context. His image appeared on forums, blogs, and later social media platforms, where it was framed alternately as inspiration, horror, or curiosity. Some posts emphasized the Soviet background, others stripped it away to highlight only the human drama of survival. This digital circulation ensured that his story reached younger generations far removed from the original Cold War context. Medical education also played a role in shaping his popular image. In lectures, textbooks, and training courses, his case was presented as the quintessential example of autosurgery. The story's endurance in teaching materials meant that medical students around the world encountered his name, often accompanied by the same striking photographs. While academic in intent, these retellings also contributed to his reputation as the archetype of self-reliant surgery. In Russia after 1991, Rogozov's story re-entered public discourse through documentaries, exhibitions, and popular science writing. Museums dedicated to polar exploration often featured his case, and national media occasionally revived it in retrospectives on Soviet Antarctic achievements. The award he had received, the Order of the Red Banner of Labor, was cited as a reminder of his official recognition, but popular treatments increasingly emphasized the human and medical dimensions rather than purely ideological ones. Another layer of popular representation came through art and literature. While no major film has yet dramatized Rogozov's story, smaller artistic works and essays have used it as metaphor. Writers have invoked his self-surgery as a symbol of self-discipline, endurance, or the human ability to confront oneself literally and figuratively. In philosophical discussions, particularly in Russian essays on resilience, his act has been interpreted as an embodiment of stoicism and duty. In Western culture, Rogozov's operation has frequently been listed in compilations of top 10 extreme survival stories, greatest medical feats, or unbelievable true stories. Such framing places his act alongside shipwreck survival, mountaineering ordeals, and war amputations. This popular packaging broadens his audience but often compresses the clinical complexity into sensational headlines. Yet it also reinforces the symbolic value. His case is consistently ranked among the most extraordinary acts of self-preservation ever recorded. Even in popular science fiction and futurist writing, echoes of Rogozov appear. Discussions of future Mars colonists, for example, sometimes invoke his case when imagining astronauts forced to perform surgery on themselves or each other. These speculative scenarios keep his story alive in the cultural imagination, projecting it forward into contexts he himself never experienced. Thus, the popular imagination treats Rogozov in overlapping ways: as a Soviet hero of endurance, as a universal symbol of human resilience, as a medical curiosity, and as an enduring image in art, education, and internet culture. The multiplicity of these representations reflects the richness of his story. It is simultaneously clinical and dramatic, private and collective, historical and timeless. Few medical events have been absorbed so widely across domains of culture, and fewer still have been anchored by such unforgettable photographs. The story of Leonid Rogozov's autoappendectomy raises a series of ethical reflections that extend far beyond the Antarctic station where it occurred. On the surface, it is a tale of individual courage, but underneath it lies a set of questions about responsibility, risk, and the limits of medical duty. At its core was the question of obligation. Rogozov was both physician and patient, but also a member of a collective. His decision to attempt the operation was not only about saving his own life, but also about preserving his role as the sole medical caretaker for the other members of the expedition. Had he died, the remaining men would have been left without a doctor in one of the most dangerous environments on Earth. This dual responsibility sharpened the ethical stakes. His survival mattered not just to him but to the survival and morale of the group. In this sense, his action can be interpreted as both self-preservation and service to others. There is also the issue of risk. Surgery carries danger even under ideal hospital conditions. In Antarctica, the risks were magnified. Infection from a non-sterile environment, uncontrolled bleeding, or collapse from exhaustion could have meant immediate death. Yet to do nothing was equally lethal. Rogozov faced a classical ethical dilemma of medicine: the balance between action and inaction when both carry danger. His decision shows the principle of necessity. When no safe option exists, the only ethical choice may be to take the path that offers even a small chance of survival. The involvement of his colleagues raises further ethical considerations. None of the men assisting were trained in medicine. By asking them to hold retractors, pass instruments, and monitor him, Rogozov placed them in a position of extreme responsibility. Yet this was not coercion. Historical accounts suggest that they volunteered readily, recognizing that his survival depended on their help. Ethically, this demonstrates a kind of shared duty within the group, where the boundaries between doctor and layperson blurred in the face of necessity. Their consent, implicit and explicit, was crucial to the legitimacy of the act. From the perspective of professional medical ethics, Rogozov's case also raises the question of self-experimentation. The history of medicine includes many physicians who used their own bodies in research or treatment, from John Hunter's self-inoculations in the 18th century to Werner Forssmann's catheterization of his own heart in 1929. These acts often straddled the line between scientific advancement and personal risk. In Rogozov's case, however, the motivation was survival rather than experiment. This distinction is ethically significant. He did not risk himself for knowledge, but because no alternative existed. Another dimension concerns prevention. Once his ordeal became widely known, institutions faced the ethical obligation to ensure such a scenario would not recur. The principle of non-maleficence, to avoid foreseeable harm, required Antarctic programs to introduce stricter medical screening and preventive appendectomies. Ethically, this was not about blaming Rogozov but about learning from his experience. His case highlighted the moral duty of institutions to minimize risks placed on individuals in extreme environments. The case also speaks to the ethics of representation. During the Soviet era, his story was framed as a triumph of heroism, sometimes stripped of its dangers and trauma. The publication of photographs amplified the drama but also exposed his suffering to public gaze. Here arises the question: to what extent is it ethical to turn a medical emergency into propaganda? While Rogozov was officially honored, there is little evidence that he sought fame. Later accounts from his family suggest he remained modest, reluctant to dramatize the event. The ethical tension lies in the difference between lived experience and public narrative. Beyond the Soviet context, his act also challenges modern bioethics by highlighting the limits of autonomy. Autonomy in medical ethics usually refers to the patient's right to make informed choices. In Rogozov's case, patient and doctor were the same person, collapsing the distinction. He consented to his own operation, performed it, and accepted the risks. This unusual merging of roles forces reflection on what autonomy means when one person occupies both positions simultaneously. Finally, his story raises philosophical questions about the physician's duty to self. Medical ethics traditionally emphasizes the duty of care to others, but physicians are also human beings with their own vulnerability. Rogozov's choice illustrates a kind of inversion. He extended his duty of care inward, treating himself with the same rigor he would have given to another patient. Ethically, this act embodies a rare harmony between professional identity and personal survival. Taken together, the ethical reflections surrounding Rogozov's autoappendectomy extend beyond a single moment in 1961. They address the responsibilities of individuals, groups, and institutions in extreme circumstances. They touch on consent, risk, duty, representation, and autonomy. Above all, they remind us that medical ethics does not operate only in lecture halls and hospitals, but also in the frozen isolation of Antarctica, where one man confronted mortality with scalpel in hand and transformed necessity into survival. Counterfactual history asks not what happened, but what might have happened under different circumstances. In Rogozov's case, the question is stark. What if the operation had failed? Considering this scenario reveals the fragile balance of survival at Novolazarevskaya Station in 1961 and highlights how much rested on the endurance of a single man. The most immediate consequence would have been his death from peritonitis or surgical complications. Appendicitis, untreated, is almost uniformly fatal in isolated environments. Had he succumbed, the expedition would have lost its only physician, leaving 12 men without medical support for the remainder of the polar winter. Any subsequent illness, accident, or injury would have gone untreated beyond first aid. Even minor conditions, frostbite, infections, dental problems, could have escalated without a doctor. The psychological blow of losing a colleague under such dramatic circumstances would also have weighed heavily on the group. For the men at the station, morale might have collapsed. They had witnessed him attempt the surgery, assisted him directly, and invested hope in his recovery. To see him die on the operating table, or in the days after, would likely have created profound guilt and trauma. Survivors' accounts in similar expedition disasters often note feelings of responsibility and helplessness. The meteorologist and driver who assisted Artemyev and Teplinsky would have lived with the memory of holding instruments while their friend failed to save himself. In a small wintering party, such psychological strain could have led to conflict, withdrawal, or depression. At the institutional level, his death would have triggered serious consequences for Soviet Antarctic policy. The 6th Soviet Antarctic expedition had already been a showcase of national capability, with the construction of Novolazarevskaya Station intended as a statement of presence on the continent. The loss of a physician under such conditions, if widely publicized, would have undermined the narrative of competence and control. Soviet authorities might have sought to suppress details or reframe the story, presenting him as a martyr rather than a victim of systemic oversight. Policy-wise, failure might have accelerated reforms. Prophylactic appendectomy for all polar expeditioners, which later became common practice, might have been instituted more quickly and universally. The requirement for redundancy, sending 2 medical professionals rather than 1, might also have been enforced earlier. Telemedicine, still decades away, might not have been immediately affected, but the recognition of communication and evacuation limits would have been sharper. In this sense, his survival delayed but did not eliminate reforms. His death might have hastened them. In terms of historical memory, a failed operation would have been remembered very differently. Instead of a story of triumph, it might have become a cautionary tale of overconfidence. The Soviet Union could have chosen to bury the episode in archives, citing only illness in official reports. Without photographs of survival, the images of him operating might never have been released. In the West, if details had leaked, it could have been framed as evidence of Soviet recklessness in sending underprepared crews into Antarctica. The Cold War context would have ensured that his death was politicized, just as his survival became propagandized. Yet even in failure, his act would not have been forgotten. medical historians would still have noted it as an extraordinary attempt, one of the rare recorded cases of autosurgery. It might have been remembered with tragic awe rather than celebration. The narrative would have emphasized human limits rather than human resilience. Instead of symbolizing survival against odds, Rogozov might have symbolized the cost of isolation and the necessity of systemic preparedness. For his family, the consequences would have been profound. Instead of later recounting his quiet modesty about the event, his son and colleagues might have preserved a different legacy. A man who tried heroically but could not overcome biology and circumstance. The family's ability to reclaim and publish his story decades later, as Vladislav did in the BMJ in 2009, might never have occurred, since the Soviet state could have suppressed records of failure. On a broader cultural level, the absence of a successful outcome would have deprived the world of one of the most iconic survival stories in medical history. Without his recovery, popular imagination might have focused instead on Ines Ramirez Perez in 2000 or Jerry Nielsen in 1999 as the defining examples of self-surgery in isolation. Rogozov would still be mentioned in academic reviews of autosurgery, but his name would not carry the same weight in collective memory. Thus, the counterfactual shows how delicately the legacy balanced on the edge of his scalpel. His survival turned a potential tragedy into an enduring emblem of resilience. His death would have shifted the moral of the story, from human triumph to institutional caution, from a legend of endurance to a warning about systemic vulnerability. In both paths, lessons would have been drawn, but the tone of remembrance, heroic versus tragic, would have diverged sharply. In the end, stories like this remind us how fragile yet unbreakable the human spirit can be. If this journey pulled you in, don't let it be the last. Hit subscribe, tap the bell, and join me here at Eternal Obsidian, where we dive into the darkest, most fascinating corners of history and survival. Until next time, stay curious and stay unshakable.